record. There we go. Okay. Welcome to the MMOA Community Podcast, brought to you by the Institute of Clinical Excellence. My name is Julie Brower. I am a member of the Older Adult Division, and I have here with me Ben Ries and Peter Drinkwine. So these two are acute care therapists at Essentia Health, which is a level 1 trauma center. It's Essentia Health St. Mary's Medical Center, and that is in Duluth, Minnesota. So I met both of these awesome guys when we brought MMOA live to Duluth a couple months ago. And it's awesome because these two are in acute care, and typically we don't get a whole lot of acute care folks coming to our course, because we are talking about deadlifts and loaded carries and squats and how to load up older adults. So that's not typically something that you would think that you would be doing in the acute care setting. So it's just awesome because we really focus on how to scale all that stuff down to folks who are sick and in the hospital. And so it's really awesome to just like get their perspective. And they're just so engaged the whole time, and they're doing just awesome things in Duluth. So Peter helped develop and implement a program, a full-time PT program in the emergency department, which is amazing. And so that primarily involves evaluating and treating older adults for falls risk, if they have orthopedic pain, if they have vestibular issues. So we are going to like really dive into that. And then Ben is actually an adjunct faculty member at the College of St. Scholastica. Did I say that right?
Yep.
Yeah. Awesome. So we're going to talk about just how they are totally crushing it in Duluth. So I'm super pumped. So guys, I first want to just like hit on like acute care in general. All right. Like you both are still in the trenches there. I am not in that setting anymore. But, you know, I want to know what you have found that's successful in bringing this fitness forward approach to that setting. And then I also want to know like what barriers and challenges you have found. So for those of you who don't understand like what a fitness forward approach is or what that means, so that is, even with our sick folks in the hospital, we are planting the seed of fitness. We're trying to introduce them to appropriately loaded exercise, planting that seed. So we're moving them from sickness to wellness to health. And then we're really trying to set them up for success to kind of continue on this like upward and onward trajectory and like do a very successful handoff to the next provider. So that is in a very like small nutshell what fitness forward means. So I just want to hear from y'all's perspective, like what has been successful? So that is in a very like small nutshell what fitness forward.
I can go first, Ben. It's hard in acute care, as you're well aware. It's hard to kind of bring that mentality in sometimes and get people to kind of see how this person who's coming in and trying to get them to trying to sell people on all these different ideas and fitness in general, like how that matters right now when I'm in the hospital for, say, my heart failure or whatnot. So one of the things that's worked for me is really getting down to what makes them tick. Like, what do you want to get back to doing? You know, what were you able to do? Maybe this is your 5th admission in the last year. What were you able to do before that? And how our role with fitness can be one piece of that puzzle to make sure that they're on those steps to getting back to their prior level, but at the same time getting back to doing the really important things that they want to do. And those are the times when in those the sessions when I can find out what makes somebody really tick, like when somebody works in a garden or really loves gardening, and we go get a bin, throw some weights in it and do basically some deadlifts and modify it at first, of course, scaling it down. But I've had people say, this is exactly what I need. This is what I want to do. And it's really cool. It's really rewarding for us. It makes me really excited about what I'm doing when I can get people to kind of buy into that and see how important it is. and make sure that they're getting their other consults and everything else that they need. So that's one of the things that works really well, is really getting down to what this person wants to do, not just what I think we think they need to do. And in our acute care mentality, a lot of the time it is like, okay, because we're so overrun right now with patients, and we're always full, that it's kind of like, who can we get out of here? But I know Ben and I have talked a lot about, we really can't forget just what we're here to do, and really what's important. So it's been really rewarding to kind of try and really emphasize this fitness forward lifestyle and approach. And yep, you might not be there quite yet, but these are the steps to get it. And this is how I can help facilitate this down the road, whether it's home health or outpatient or a rehab stay.
Yeah, I love that, kind of like the digging deeper into the goals, and not just to return to PLOF and to be
and it's not
independent. Like, it doesn't really mean anything for a lot of folks.
And that's not a normal like acute care mentality. That really wasn't how it was when we started to work in acute care, but we've worked really hard to kind of change that, our mentality. And I don't know if I'd say a culture, but try and get everybody on board with that, even beyond PTs. Yeah,
I love that. Ben, anything to add to a successful story before we go into some challenges?
Yeah, so I think I echo a lot of what Pete says, and I would say that we are trying to change that culture and trying to be better for our patients and get outside of that normal, like you said, just goals like, hey, you have to go walk 150 feet, 2-3 stairs, see you later, we're not going to see any more. I really try to dig deep, and I really try to give these folks time. And if you can give them the time and you listen to them, they'll tell you exactly what they need to do and what their goals are. And I try to work backwards to get to that point. Drawing on a very recent patient example, an 89-year-old guy, it was actually a Division I NCAA hockey player in the 1950s, so quite a while ago. But he told me, he said one of the hardest things for him in the past few years was that he lost the ability to stand from a chair without using his upper extremities. And that was something that has affected him into his life. And I was like, okay, like, we need to work on some lower extremity power. Like, let's do this, like, and I was able to scale an activity for him. I think what I did was he couldn't stand from like a standard height chair. So I put him on the hospital bed and I raised the bed up to appropriate height, and he was able to rep out some sit to stands. I had him do it as quickly as he could. And, he looked at me and he's like, that was kind of fun. So it's more fun for the patient when you get to do some of this stuff. And I think that makes it more fun for us and makes work more enjoyable. I mean, I think I speak for Pete when I say that it's more enjoyable to go to work and work with these folks when you can bring them some joy and happiness too.
Yeah, absolutely. Have both of you been like surprised at, like, after you start to like load them up and do a squat or do a deadlift, like, have you been surprised at what these people can do? Like, have you had days where you're like, you are so sick, and just looking at you and reading your chart, I would assume one thing, and then they totally just completely blow it out of the water?
I would say that happens to me like every day. You always
Every
get this idea of like, what are you going to be able to do? And then you look at the person and you're like, huh. And you get them up, you get them moving, you load them appropriately for whatever task you're doing. And I've been very surprised at how much our 90-year-old ladies can do, which is the stereotype of frail and sarcopenic, and maybe they are sarcopenic, but like they're feisty. Most people are, and they want to get up and they want to do things. Generally, of course, you can't generalize that to everybody, but yeah, I mean, we both work in our ICUs too, fairly regularly, and there's a lot of people who can do more than just a transfer to a chair after even being intubated for days, if so that's really surprising too, is we've had to, I know I've had to kind of stop and think and say, can this person do more? Like, yeah, they probably can. Or at least let's try it. It's safe to do that. Let's see if they can do another set. And very much like you guys with the older adult division and MMOA talk about, like intentional underdosing at first too. That happens a lot in acute care, because we definitely don't want people hating us the next day and not wanting to do anything. But once you show people too that they can get up and move, and I mean, nobody wants to lay in bed, so it's been a very different response after we've kind of been doing a fitness forward approach, as far as for me at least, the responses I've gotten, and people saying, you're going to come back tomorrow, right? Yeah, we'll do our best, depending on the day, but it's been really fun.
That's awesome, man. Having fun at work since when? Like, that's
Right.
great. And I mean, just to sum that up, it's like you dig into the roles, and then it makes it so much easier, right? Like, you know exactly what to work on. You're not having to like rack your brain to figure out what exercises do I do. They're basically telling you exactly how to structure your session. And then it's so nice, because when you start to really implement all of this, you're thinking like beyond that 3 to 5 day length of stay. And it's like, where are they going to be in 2 weeks? Where are they going to be in 2 months? Where are they going to be in 2 years? Where do they want to go? And then it's like, okay, what do we need to do to get you there? So that's awesome. The point I love the most is that it's like more fun to do your jobs, because I think in this climate after COVID, but still, I mean, it's still out there. It's still hard in that setting. Having more fun at work is pretty critical for like our own like mental and emotional health. So those are awesome. Those are great success stories. So like, what are the challenges to implementing this? Like, what are your challenges? What are your barriers? Like, give me just like 2 of the biggest barriers that you see. So those are awesome. Those are great success stories.
I would say number one, and I would bet, I'll be curious to see if Ben agrees, but it's time. We have so many people to see in the hospital, because we're full, and I know it's the same everywhere, but there's just not enough. You have to balance your time seeing people, because I could easily spend 45 minutes with somebody, or an hour, but that might mean I don't see somebody else. So I really have to think about, unfortunately, the risks, not the risks, benefits, but the benefits of seeing one person over the other, or do I kind of cut the session short and go see somebody else too? For me, that's the biggest one. I don't have enough time, but I know that's an issue in many settings too. So
do you think more staff would, like, if you're a PT team, I know you're hurting right now in terms of staff, but and you're so full, but do you think having more people on the team would be helpful, or is it not that it's that you're just getting inappropriate referrals, so you're having to spin your wheels because you're having to get rid of consults that never should have been there in the first place? What do you think is the main driver?
I can speak to that a little bit if you want, Pete.
Mm-hmm.
So Pete and I both worked at St. Mary's Hospital for 6 years now, and when we started, we probably had about half the team there per day that we do now, and we doubled our PT and OT team in an effort to try to see people more often, like even BID treatments. But what happened was that gave providers we had a lot more awareness with providers, and we just started getting more consults. And yes, some of them are inappropriate, but largely I think they just have kind of learned more of all the things that we can do and how we can help. And so we still are in this process where, I mean, the other day at work, and this is not a normal day, but I had 27 patients to triage, and I might get to 7 of those, especially with all those charts that I have to get into. But that's not normal. I mean, I would say our normal numbers are, 15, sometimes 20. But it just seems like when we try to increase staff, there's just an increased demand. And I think that's good that we're showing our value and we're getting more of these consults. But Pete's right, like in terms of the challenges, time is a big one. especially like you have these really fun sessions with people and they ask you like, hey, are you going to come back tomorrow? And I'm like genuinely like a really nice person. I love to work with these people, and it hurts me to tell them like, you know what, I'm really going to try to stop by tomorrow, but if not tomorrow, it will be the next day. And that's hard to like let someone down. But that's just the nature of acute care and where we are right now.
Yeah.
I'll say the other challenge for me is probably just the constraints of a hospital. I mean, you have to get pretty creative in terms of what you're going to load up people with. And I mean, sometimes we even have a hard time finding chairs for these folks to get them out of bed and keep them out of bed. So to find the tools that you need, or the tools that you can make into the tools that you need, is sometimes a challenge. But we have a lot of good brains that we can pick for ideas, and it's just a challenge, but it's definitely, we're able to overcome that too.
Yeah, really tough. So, and that's like a nice segue, because if we think about like the barriers there, even like not having staff, or you guys are so full, and if I think of like what is a massive opportunity for clinicians, like what are we not doing, like what are we missing? And I think this PTs being in the ED is something that is not routine for a lot of systems. I mean, I know, and when I was still in acute care, it was kind of like starting to come about. We were talking about it, people were doing in-services on it, and we may throw 1 or 2 people down there sporadically throughout the day. However, nowhere I know of, until I talked to both of you, is there a full-time established program of PTs like in the emergency department, because that right there, you can help prevent admissions that don't need to be admitted, right? And you can kind of like save, if you think of down the road, can you save that person taking up a hospital bed and then taking up staff and then taking up, the medical costs of unnecessary imaging, all the other things that can be a sequelae from that. That's such like an opportunity. I think that's something that we're missing in so many programs. But then again, it's like, well, that takes up how much of your staff that's in the ED, right? So these are my thoughts, but like Peter and like both of y'all, I would just love to hear like how your program started. Was it one person with an idea and you had to come with a bunch of research and a bunch of evidence to say, hey, hospital system, we can save you a bunch of dollars. Like we can turn beds over quicker. Like how did that come into play? Because you need to split your staff to do that. So it must be having such a so beneficial if you have a full department there.
Yeah, so that is a topic. I'm going to give you the really short version, because the PT, the guy who was this original, it was his baby that started, it was his idea. He was the leading force behind it, but it wasn't possible until we had more staff and I came along with someone else who was interested. So we've actually done this on how to start an ED program, like at national conferences and stuff. So that could be an hour-long story, but of course I'm gonna tell it to you really quick. But his name is John Sipe. He's an awesome PT. He is a big picture thinker, which is awesome. And so he's got these great ideas. He was working one day before Ben and I were even out of PT school and thought about we would occasionally, our people would get called down into the ED for maybe like kind of like that home safety assessment, or sometimes a BPPV vestibular assessment, but pretty rare because they didn't know what most emergency medicine providers don't know what a PT is. So he worked his way into the ED. He asked permission from our manager at that time to just go write his notes in the ED. And then he sold himself to them slowly, like literally just like chit-chatting, like, hey, I'm John. This is what I do. This is what I have to offer. I can help see this person with back pain if you want. Then he eventually did a pilot study within our system and showed that it was financially and fiscally possible and beneficial. And that won our finance department over. So he had all this permission to implement full-time, business hours, basically 5 days a week, Monday through Friday, PT in our emergency department. And then we didn't have enough staff to give. It's that exact problem you're talking about. We did at that point, and this was right when Ben and I started to work, like 6 years ago. They didn't have enough staff to even cover the regular hospital, so we had to wait until he found the right person. He was one of my CIs. I got experience. It was exactly what I never knew I wanted to do, and I got to. It still took a year and a half, almost 2 years before we were in there full time for fiscal reasons, but also just staffing wise. And so we got permission, and it's been very, very successful for the last 4 years. And exactly like what you said, we see a lot of older adults and we do see younger people too, of course, but generally a lot of orthopedic issues, orthopedic pain, back pain, neck pain, shoulder pain, hip pain, anything you can imagine. The physicians use us for orthopedic differential diagnosis a lot, which is great. We do a lot of kind of somebody falls, maybe they did break something, maybe they didn't, but it's not surgical. Are they safe to go back home to their assisted living? Do they need to go straight to short-term rehab and avoid a hospital admission? Are they just not safe to go home and they do need to stay admitted? Did we get them up and moving and kind of, I would say, maybe stress them a little bit more than just walking, and find that they were struggling and probably can't do the stairs to get into their house, and they live alone? We do our PT things. Like, we're able to look at the whole picture and do more than just, can this patient walk? Can this person walk? Which, to no fault of anybody, nurses or physicians or PAs or NPs working in the ED, that's not their training. That's our training. So we're really, really lucky because they love us. They're like, I've had one physician say, like, I didn't realize what I was missing until you guys started to work here, because I always felt like I wasn't able to give the person what they needed, and now you're here and you can. So he uses us all the time.
So what do you think is like the most, like, to the physicians that are in the ED, to the other staff, like, what do they tell you is like the greatest benefit? I know you just mentioned one, like, you can give time to these people because they're having to go minute to minute, keep people alive. What is, is there anything else that they have said, like, this is the greatest benefit to us because XYZ?
I do think it is a little bit dependent on each person, but I've heard some physicians tell me that they really appreciate that. They're like, this person has back pain and I know they're not dying from it. I don't know what to do for them. Like, they literally just throw the ball in our court when they're like, you're not dying from back pain, because that's what they're trained to do, right? Yeah. So instead of just either giving them nothing and sending them home, or giving them an opioid, which of course we don't want to do, and sending them home, they just completely trust our opinion, which is great. I mean, we've earned that trust, we've worked for it, but a lot of docs are really happy with that we could treat BPPV immediately and help differentially diagnose it. We've had some, I don't know if I'd say success stories, but there's been some things where we really help a lot of the times we'll help kind of guide their further workup. And they're like, well, do you think this is musculoskeletal? Or is this person safe to go home or not? Just the other day, I think it was a week or two ago, I had somebody that was supposed to kind of just be like a home safety evaluation, and they had fallen and they had hip pain, and I spent time with them, stood them, I had them get up, and they could still barely walk, and their imaging had been negative, but it wasn't the right imaging, I guess, because I went back and the doc was like, oh, they need a CT of their hip then, and they found like multiple pelvic fractures that were not there on the pelvic x-ray. So they kind of use us as like
it checks and balances almost, kind of.
Yes. Yep. Yeah. Like, oh, this doesn't seem musculoskeletal, I need to look more, because they're not expert musculoskeletal people.
Right. It kind of brings another, like, I think of this as like being like when we hear frontline providers, right, or frontline workers. I know through COVID, it was like the people who were in the ICU going into these COVID rooms day in and day out. Like, that's one way to think about it. But I think of PTs being the ED is that as well, because if you can take someone and be able to be that checks and balances and prevent some really adverse health outcomes, right? And then get them, streamline them to where they need to go. That to me is like acting at top of license, being a frontline provider. I mean, if you take an example, like I'm just interested because I think a lot of folks listening would be interested, like when someone comes in and let's say they're in excruciating back pain, like I just want to hear like how does that go from when you're consulting on this person and you're evaluating them until you make a referral for where they need to go afterwards? How does that, you know, what assessments are you doing? Are you pretty much acting as like an outpatient ortho PT, but in the hospital? Yeah, tell me about that specific case.
Yeah, I really like that you also mentioned top of the license, because that's kind of exactly how we view it. Is we kind of have to be practicing at the top of kind of all of our ortho, neuro, cardiac, whatever we want to call all these different things, even though we're like, you know, one person, we kind of have to be up to date on all that stuff. So that's happened many times, and that could that severe back pain person, you know, sometimes they come in by ambulance and EMS and they can't get out of the bed. Sometimes it depends on this is kind of my like pain education or pain specialist background, but sometimes we really have to almost cut through the anxiety and using some of the anxiety and the fear, I should say, of back pain, because this may be truly acute, or it may be kind of acute on chronic, or this has just been a slowly progressive thing. So if I get consulted on somebody like that, we always talk with the physician first, get the lowdown, see what the deal is, see what I want to know what their thoughts are too. And because if they're consulting me, they're obviously not too worried that, again, this is like a super serious, severe thing. They have pain, but not life-threatening, I guess. So it may be, of course, I don't want to say it depends, because that's like that terrible phrase, but it can, you know, I go in and I sit down and get on the same level with the patient. Sometimes they're already laying and prone. Sometimes they're just writhing in pain on their back. Sometimes they're fairly comfortable until they start to move. So yeah, I 100% act like an outpatient orthopedic PT in a hospital. And the first thing that we really do first, I should say, the first thing that we really make sure we do is make sure that there aren't any kind of subtle red flags or subtle signs that maybe this isn't musculoskeletal. And then as long as the patient's willing to and at least try, I'll do a movement screen. I'm going to see if I can find easy and aggravating factors. I'm going to, of course, listen to their story, because the subjective is so beneficial. And then I'm going to use my objective to confirm that that hypothesis. And sometimes it's just providing reassurance after that exam to the patient that you're going to be okay. This is not going to be life-threatening, debilitated. I'm going to give you something to start with. I want you to follow up an outpatient PT. This is how to contact them. Or our physicians are super good at putting in referrals. Our system has worked it out. So if the ER docs put in the referral, they don't have to co-sign it, since they're never going to see that patient again. So they've worked that out, which was a bit of an issue at first, but that's a credit to our system for figuring that out, because that's exactly streamlined, getting the patients where they need to be. And again, kind of like it also could be like, ooh, these are concerning things actually. And then I go back to the doc and say, the provider, and say, I don't know, this doesn't sound musculoskeletal. This doesn't sound right. They're not getting better, or I can't make them better no matter what. I'm more concerned this isn't musculoskeletal. And I got to spend more than a couple minutes with them. They told me this X, Y, and Z, like they fell down the stairs last week, which happened once, and the person had a compression fracture with, a little bit of impingement on their spinal cord, but they had some dementia, or it was dementia. And so unfortunately, and again, to no fault of that ER provider, they did exactly what they're trained to do, but they even had CTs. It just wasn't of the right area because the person didn't tell them that they had this pain that I was able to find, and that, oh yeah, I had fallen down a flight of stairs. So
again, it is really like a checks and balances where it's like the doctor, like and we want them to, like you said, we want them to save people's lives, and we want them to be minute to minute, be able to make these like very quick decisions. And then the therapist can be coming in and doing this like head to toe, considering all factors, and then bringing in like psychosocial aspects too, from like a chronic, with pain science background knowledge and all of that. And you can take someone who more than likely without that could have been admitted and be given opioids or be given unnecessary imaging, and then on and on and on, right? Or get admitted to the floor and potentially just get underdosed exercise, and then who knows, right? So then how would it go? So how many people are in your, like, how many are in the ED? How many clinicians?
So each day there's one of us in there, just with the size, but there are 3 of us who kind of regularly rotate through there.
Got it. Okay.
Yep.
Cool. So let's say like that person with the back pain, it's not musculoskeletal. Maybe there needs to be some imaging. Maybe you're thinking there's some spinal cord, compression going on. They go to the floor, or they go to the ICU, or they get admitted. So then, let's say like Ben, you were seeing them out on the floor or out, in the ICU. Like, how are you guys transitioning that care from what has been going on beyond just like, oh, I have your note, but like, are you guys doing like a very, just being meticulous about that transition from what you're doing in the ED to then what is happening after they're admitted? Like, is there good collaboration, communication there?
So I'm going to jump in real quick that yes, there is, but we're lucky enough that I can follow that patient up to the floor the next day if I need to.
That's amazing.
Because all 3 of the PTs that do work in the ED are full time. So we have that ability to maintain the continuity of care. But if not, I'll let Ben talk. But yes, I would absolutely be communicating with Ben.
Got it.
What's going on.
Yeah. Yeah. Cool.
Yeah, I don't really have anything to add to that. Pete is our guy in the ED right now, so that is his baby, and it's cool to see him shine down there. And I guess the one thing that I would reinforce is he is an outpatient PT that's down there, but he has a lot of other tools that he can use with the providers and that collaboration, being able to have those conversations. And if there's something that you need, whether it maybe is an image if it's appropriate, or maybe getting that patient something for medication so then he can do what he needs to do. Like he has that, and we have that right at our fingers, which is I think it's better than being an outpatient PT in that sense.
Yeah. Yeah.
The one last little to finish off, you're kind of like, what does it look like? I know this is, I want to say, I don't want it to get the sense that it's almost like not doom and gloom, but like all these like bad things, because red flag situations aren't that often, but somebody may come in with severe back pain, or even just bad enough back pain that they need to come in, and I can do a lumbar manip if that's the right thing, and give them some exercises, and they could be good then. If I'm using the appropriate screening tools, maybe they don't need outpatient follow-up. Maybe that's all they need because they have very low risk factors for persistent pain and chronicity, and they're going to be fine and they're healthy. They don't have comorbidities. So we're able to use a lot of those skills too. Or maybe I tell them to go into extension when all they've been doing is flexion if they have a really hot radicular pain and they're kind of like mind is blown. So it can go many ways.
Doing a lumbar manipulation in the ED, like just like blows my mind, right? I mean, talk about taking like every single skill set, like a primary care skill set and acute care. You have to know cardiovascular, you have to know your neuro, and then bringing in spinal manipulation. Like that's wild. And I think we get a lot of questions like from outpatient ortho PTs who are like, I may want to like switch into acute. They want better hours. They want a different lifestyle. And they're like, but I could never use any of my skills here. I could never use any of my skills here, and I'm just going to treat sick people and it's boring, right? Like, this is not the case in this. I mean, again, this is a niche type of environment for a PT, but that's pretty awesome. So what do you think, like, what do you guys think, like, individuals who want to be working in the ED? My first question is, do therapists, like, is this kind of like when therapists want to go to the ICU? Are therapists jumping at the bit to be like, get me in the rotation? Like, I want to have a chance to be in the ED.
Let's say, do therapists jump at the bit to get to the ICU? I feel like many people are scared. It's the same thing. A lot of people are scared of the ED, and that's understandable because it is a totally different mindset.
Yeah.
Kind of like an ICU, I would say. You know, it is a different, I don't want to say different skill, but it's a different way of thinking and whatnot. So to get into it, I would say many people are not jumping at the bit, but probably largely because, at least like most people don't go into, kind of like what you're saying, like they don't go into acute care in a advertised job that's like acute care in this, you know, trauma hospital, and expect to be doing kind of fairly complex vestibular evaluations sometimes, and outpatient orthopedics, in addition to all the kind of home safety stuff. So there are people who want to do that, though. And of course, there's communities on Facebook, there's listservs, there's whatnot of these ED-PT providers. There's probably 30 hospitals throughout the whole country who have a part or full-time PT in their ED. But students are kind of the big people who are realizing that they're the easiest people to reach, and they're the people who have, not that we can't take any person and train them to do it, if they're really interested enough to do it, because that's kind of part of it. You got to have an interest, you got to have a passion, because it's a whole lot of different skills that you may have to use one patient right after another. And there is like a toolkit that the APTA put out for the acute care section on what their recommendations are. So usually a couple years of experience, just learning how to be a PT in general. And finding a mentor is like the really important part, because it is, as we've talked about, it is such a niche. It is such a small, specialized thing, but it's growing. Within, even in the last 4 years, at least on social media and that kind of stuff, there's been more recognition of it. And there's a couple, I would say, leaders throughout the country who are really pushing and doing a good job to make it more well known.
Yeah. And one of the things that you mentioned that, like just us talking kind of back and forth, is how respected you guys are down there. I mean, it's so different. It's wild. I mean, I know in the ICU, you know, we're doing rounds and we're saying, get this person off of propofol, put them on, you know, Presidex, like, yeah, let's try and like get the tube out today. I mean, you have really good collaboration in the ICU, and then you go to the medical floors and it's a completely different ballgame. I wouldn't assume that in the ED they would be so respectful. I guess my assumption is wrong, but my initial assumption would be like, they're just going so fast that it's kind of like, you're not important, push you aside. So it's so awesome to hear that they're so respectful and they're taking your recommendations, and they want your help, and they really, really respect your opinion and your assessments. Like, that's really cool. I mean, anyone would love to be able to work just in that environment, because the big pushback that we hear a lot is providers don't take our recommendations, you know, and they don't value us. So it's a whole different world when you're in an environment where you're valued, which is really awesome.
It's unreal. It makes for immense like job satisfaction, because that's exactly it. They're like, tell me what to do with this person. Like, I know they're not dying, please tell me what to do so I can, because they want what's best for the patient too. And so they're like, tell me what I need to do. Do I need to refer them here? Do I need to refer them to neurosurgery? What do I need to do? They're awesome about, we have a social worker and a nurse case manager that sit right next to us in their ED. And they are also great resources. So if we need to get someone avoid an admission or get home healthcare set up or whatnot, that's also a great resource too. And if the providers, you know, if we recommend outpatient, they put in that referral. which is great. We have direct access in Minnesota, but it does kind of get the job faster, or get them into outpatient faster because they're kind of already on our radar, or I should say Essentia's radar, or whatever. But
Yeah. That's
the fact that they just absolutely respect us, and they treat us truly as consultants, not like ordered.
Yeah.
We're on the same level to them as the cardiologist.
Cardiology. I was just gonna say, like,
Yep.
we need a neuroconsult. Like, that's such a, like, I love that, putting it that, like, a consult versus just a order set, an automatic order set. That's really cool.
It's super cool.
So what would be, so one last question before we kind of switch gears a little bit, what would be like what's your number one piece of advice for somebody who is in acute care? And let's say, it's kind of same as my facility. We had individuals who kind of went down to the ED every now and then. It wasn't an established program, but they were open to it. If there are clinicians out there who would be interested in working in this setting, what would you recommend they do to really kind of advocate for themselves or advocate for that type of program?
Yeah, for sure. One of the best things you can do is get a hold of somebody, reach out to myself or anybody that you're aware of who has an established program, because there are so many niches. Like, having that ED mentor is huge, to say, well, I'm kind of coming up with this problem today. Like, I wouldn't be where I am if I didn't have my mentor at all. John Sipe was my mentor, and this program never would have happened. I wouldn't be in the place where I am today. So that has made such a huge impact. But just kind of getting to know the right people too. You have to get to know those ED providers as humans, not just doctor or physicians, because they're normal people too. And that's exactly how the relationship works. Like, you talk to them like a normal person, you talk about what their interests are, what did they do this weekend, and then they trust you. So you have to be very, very patient and earn trust of everybody involved in that system.
Sweet. Awesome. Yeah. So I'll put your, if folks want to reach out to you, is that cool? Do you want to do email?
Absolutely.
I'll put it in the show notes.
Yeah,
okay.
you can put my email. Yep, totally fine.
Very cool. Awesome. I love it. Doing manipulations in the ED. I can't, it's amazing. I can't imagine. Okay, sweet. Let's switch gears a little bit. All right, Ben, you're doing clinical care and you're teaching. How in the world do you do it? I think at this stage in a lot of clinicians' lives, well, it depends how long you've been practicing for, but I know obviously I am here. Clinicians start to feel like, I want to get more into the teaching space. I like clinical care. I still want to do it, but I'm really interested in teaching. I want to have an influence on students. Like, how did you get involved in it? What exactly are you teaching? Tell us.
Yeah, so I am pretty fortunate. I don't work full time. I'm a 0.8, so I work 8 days out of every 14. And being that we work in a hospital setting, some of those are weekends, so I have some flexibility with my weekdays, and also a very flexible employer. So we don't necessarily work an 8 to 4:30 job like most people. So if I have a course that I want to teach, or a course I'm interested in teaching, I can kind of flex my hours around that and make up the difference. So I guess going backwards a little bit, Pete and I both went to physical therapy school at St. Scholastica, which just happens to be in Duluth, which is also where we're working in the hospital. So I've kind of kept in contact with them, and Pete has as well. And I've just had good opportunities come up where there are courses where they need an adjunct or could use an adjunct, and it's courses that I have an interest in. So I've slowly kind of taken on a course for 1 year, and then another course another year. And I think I have 3 courses this year. So I teach cardiopulmonary in the fall, which is second-year PT students. And then Pete and I are involved in a patient-client management course, which generally that means we take the bulk of 48 students and run them through an afternoon in the life of the acute care PT, and just kind of get them some exposure and some just a general idea of what acute care is, because some of these students do not have acute care internships. And then the other course that I teach, which is my passion is geriatrics, and that's actually coming up this summer. So I'll be taking, kind of splitting that course 50-50 with a lead faculty. So I'll have a fair amount of responsibility, but it is a summer course, and it's a 6-week, 2 days a week for 2 hours. So I'll be doing a few lectures at 8 in the morning and then coming to work at 10 o'clock afterwards.
Yeah. So it's so amazing, like, to get a teaching job, because typically if you want to go into some sort of teaching, you have to have research experience, right? Like that's the typical pathway. Did you have to do any research all along the way, like very specifically for a short amount of time, or was this it kind of came about without having the big research piece to it? Did you have to do any research all along the way, like very specifically for a short amount of time? Oh no, he's muted.
Can you hear me now?
Yes.
Sorry, I am struggling. I am camping with my family. I'm in my truck and it is storming out, so I'm just surprised that you all can hear me.
We're doing it.
I did not have any research experience. I don't know if our program is necessarily different, but they had a few adjunct faculty when Pete and I were in school that primarily brought clinical knowledge. And so that's kind of what I do, is I get to tell the fun stories of these patient examples, and all the kids' attention is just on me. Their eyes light up and they're like, whoa, that's how you apply the stuff that you're teaching us in the course. Like, so they really value that clinical experience in terms of adjunct faculty. If I was going to be a full-time faculty member, there is a certain amount of research that you have to do, and it would be tough to land that job without that research background, but I would say not impossible.
That's awesome. Yeah, it's pretty rare. I think a lot of people would be like super interested in like, how do I get that where I don't have to go through a big like research route? That's so cool. So what are your geriatrics course? Like, what does that curriculum look like? Like, what are you teaching students? Like, do you teach the whole thing? Do you have a certain section?
Yeah, so this is, this year, basically, I am splitting the course with another faculty, and we each have like 4 or 5 lectures and then a lot of labs. You would basically take everything that you teach in the MMOA course and spread that out with a little bit more depth in some places. But yeah, generally, I mean, we're teaching kids how to load these folks and the best test to use, and really trying to take that ageist belief out of it and treat the patient and give them what they can tolerate.
Yeah, that's amazing. So students are getting exposure to PT version 2.0, being your student. That's really, and so how are students like, what the heck, this is weird? Are they totally all about it? Are they talking to their other friends and other programs and they're like, this is what we're learning? Like, how is it being received?
I guess we'll see more this summer. I'd have a better answer for you, because I'll be able to implement more of the stuff that I learned in MMOA from this past year, or this recent course that we took. But I will say right now, Pete and I, so we're also clinical instructors, and we have a student that's with us right now for 12 weeks, and talking about when you chart review these patients and you're like, oh man, like they're barely going to be able to do this, and they surprise you. I know you asked that question earlier, and I think that happens a lot with students. Like we had a lady that was like an 88-year-old hip fracture. She hasn't been out of bed, had surgery, and just looking at the patient, we're like, oh man, we're probably going to need to use some sort of like a lift equipment here. Like she's in a lot of pain, like can't actively move her leg. Like, and so just taking that patient, and then they will surprise you. Like that's not always the case. Like they may be able to walk and they may be able to tolerate pain better than you or I could. So I think that those kinds of things surprise students a lot. Like you did what with who? Like, and they might talk about it at lunch or talk about it to their other classmates and stuff. And they're just like, wow, like you wouldn't believe that what my CI made me do or had me do with this patient, like that kind of stuff.
Yeah. I love that. You are breaking a lot of ageist assumptions like really early. leading, we want to lead by assessments over assumptions, and for students to get that early is wild and so beneficial. And then taking them into like doing where you guys are taking them into, so you're taking them into the hospital and showing them a day in the life. So not just the didactic portion, like, labs in a classroom or it's just different than actually getting in there and seeing what it actually looks like and what a day looks like and what caseload looks like, and kind of pairing those two. I mean, my acute care course was, we talked about like medications for like a week, right? Like just things that are not like are important, but we're not anywhere near what, the scope of what we can do in that setting and what's important with folks. That's really awesome. Very, very, very progressive way to introduce students into the field. So that's so badass. I love it. Very cool.
And then summer, so Pete helps out with the course in the summer too, and we do ICU simulation with these students with like a mannequin that it's a collaboration with nursing, and the mannequin actually has like vitals that correspond with mobilizing that patient out of bed for the first time and stuff too. So we do some sim stuff too, which is pretty cool.
Yeah, that's awesome. You guys are like light years ahead, and it's fantastic. It's so cool. And everyone in Duluth is like the nicest person ever. Like seriously, like Minnesota nice. That's a thing. Yep. Maybe people will just start to move to Minnesota and like work with you guys and take your classes. Like it's only a little cold, just a little cold, right?
Yeah, it depends on the day. Yeah. Tomorrow probably will be after it was 100 today. So yeah.
100 degrees today. There you go. You get summer. I love it. Awesome, guys. Oh gosh, it is almost 10 o'clock. That hour goes by really fast. Any parting comments, thoughts, anything you want to share with anyone who is watching or who is going to listen to this later that you want to kind of leave with them? Any parting comments?
I think I just want to tell you guys how much we appreciate you, because it is like norm breaking, as what you guys are doing, and you're so good at it. So I feel really lucky to be here talking with you, and it's been a huge eye opener. You guys do such a great job on like social media and also and whatnot. So it's literally like free resources. Like the MMOA division is so fantastic. So that's one of the points I wanted to leave with. You guys are great, and at the same time, like anybody who's in acute care, kind of, I don't want to push your boundaries. I guess I would say like rethink. Can I do something else? How can I load this patient? How can I make it an appropriate scaling down of a deadlift or a carry or whatnot? We've had so many people doing resisted walker pushes after the MMOA course, and I see them, like I'll read it in the note after I follow up with the patient. I'm like, yes, this is great. So you kind of have to be, somebody's got to start that movement too. And I know a lot of acute care hospitals aren't necessarily like that, but we can make a big difference in acute care, because these people have the most to gain. They have the most room to improve, I should say. Not that every setting, of course, isn't important, but the person who can barely stand has the most to benefit from us and being loaded appropriately. So,
heck yeah.
Yeah.
Love it. Preach.
Yeah. I would just echo what Pete says. I mean, it gets me excited to listen to you guys drive to work in the morning. Keep doing what you're doing. We appreciate being here with you. This is awesome. And if we can help anyone in any way, Pete and I are more than willing to help. So feel free to reach out to either of us or both of us. We want what's best for our patients, and we want what's best for our profession as well.
Yeah. I love it. Yeah, we totally, I mean, I'm sure so many people would love to use you guys as resources. Like anyone who's getting real like starry-eyed about how can I get into the ED, Peter, like I'm sure people would love to hear too, like just like an example, like we did back pain, like what happens if it's an older adult who has a fall? Like what could I do in that situation? I'm sure people have a lot of thoughts of things that they could reach out and Ben, from just a teaching perspective, so many clinicians in our lives right now are like, how do I get involved in teaching? Like, this is where I want to go, or this is how I want to have an influence. So yeah, you two are awesome. And I'll make sure to put your contact info and show notes and stuff. And with that, have an awesome rest of your night. Ben, thank you for interrupting vacation and sitting in your truck to be with us. Yeah, totally appreciate it.
Awesome. Thank you so much for asking us to be here.
Totally. All right, guys. Talk soon.
See ya.
Thank